So I am Andrew Brandner. I am a volunteer. I live in the Chicagoland area. I am from New York. And, of course, I'm sporting my Michigan Wolverine sweatshirt today because I'm a U of M grad. See? Look at that. It's always in every audience. It becomes a real discussion piece. So, and usually I get some things from the rivals as well, usually with the four-letter word things. Anyway, so before Dr. McIver gets here, and he should be here approximately 10 minutes-ish, I'm going to introduce Pam Lowry. So Pam is a registered nurse at the Department of Head and Neck and Endocrine Oncology with the Moffitt Cancer Center in Tampa. So she works with Dr. McIver, and she's here. So he didn't get here, but you got here. So anyway, Pam Lowry, good morning.
Nothing like getting thrown into this at the last minute. So good morning, everyone. I recognize a lot of faces, and it's not working. Can you hear me? Can you hear me now? Can you hear me now? Okay. I recognize a lot of faces in the audience and thoroughly enjoyed getting to know so many different people yesterday and hearing the stories. It's so inspiring. Dr. McIver, I think everybody pretty much knows, is just truly a gift for patients, and he's such a delight to work with. Dr. McIver came to Moffitt Cancer Center just about a year and a half ago now, and I came on board. My whole background is 22 years of nothing but ER and trauma nursing. I knew nothing about oncology, and I certainly knew less about endocrine. He and I were laughing when I came to interview. I said, I can tell you exactly what to do with a sick cancer patient, and that's send him to ICU and get him out of my ER. And as far as anything with endocrine, usually a diabetic, and I said, treat it, get him out of my ER. But he said one of the things that I had was the skills that he was looking for, how to deal with patients with complex situations. So he and I set out to blaze a path because he was brand new to Moffitt and I was brand new to Moffitt. So we decided to set sail on a course and see what we could do. And since we were both new to Moffitt, we did a lot of, we didn't know that, why can't we do that? So in this time period, he and I have successfully set up a thyroid nodule clinic where every Monday we bring up to 7 patients in. We will do a fine needle aspiration biopsy of a thyroid nodule if warranted, send the patients away for about 4 hours, bring them back with their pathology results. If the biopsy comes back as suspicious or diagnostic for cancer, the patients leave with an appointment to see a surgeon and to get a full neck ultrasound, and then we'll bring them back into our clinic at the main campus the same day that they see the surgeon. In this 1 year's time, we started October 29th is when we opened the clinic, and we've done over 150 patients through the clinic. We've put more than half of them through surgery, gotten them all through, and we're getting probably now our third batch that's come through after surgery, and we've sent them away and said, you're doing good. We'll see you in 6 months. We've had a lot of patients that have followed Dr. McIver down from the Mayo Clinic, and we've gotten a lot of patients from the community that have come in to see us, just to get either a second opinion or just to get some guidance because they feel like they've been swimming uphill and haven't been able to get their questions answered. If anybody here knows Dr. McIver and our clinic, we notoriously run behind schedule. And at the beginning, as new to an outpatient clinic, I kept thinking, oh my gosh, we're never going to get out of here, and he's getting behind. But then I stopped and I realized that every single patient that he sees, whether or not it's a new patient, it's an established patient, he is going to sit down and give them the time that they need. We created a policy, and everybody told me I was nuts when we started, that I encourage my patients, if you have questions, if you have concerns, if something's not right, you know your body, call me. Let's see what we can do about it. I would rather have you reach out to us and say, something's off, than sit there and say, well, I'm not due to come back for 6 months and I don't want to bother you. That's what we're here for. We're here to, move you forward and get you going. I sat in on a lecture yesterday, and one of the first things that came up was the frustration level that a lot of you are having with, reaching out to your care providers and their teams and everything. So I put it out there and I said, from a nursing perspective, what can I do? And I think that that's something we truly need to look at and say, from a nursing perspective, Dr. McIver frequently says, he says, you run my practice, not me. But, what can we do to help our patients as they transition? A lot of our patients are coming in and they are very, very stable. They've got, a minimal disease burden, and, we are seeing them doing their ultrasound, checking their labs, and we're saying, we will literally see you in a year. Call if there's any problems. We also have more and more patients that we're starting to see that are starting to run into trouble. And one of the things that we've also done is we've brought in a brand new head and neck medical oncologist who is working very closely in tandem with Dr. McIver. And I've started kind of juggling both hats now. I've got our medical oncologist and Dr. McIver. And we're starting to transition a lot more of our advanced thyroid cancers to the medical oncologist. And we continue the team effort as we transition patients to needing, TKIs and chemotherapy. We're taking them on. They're needing more scans. And we're still keeping it open and available for our patients. Dr. McIver is always right there. A lot of our patients now are getting hospitalized for different things as they go, further with the disease process with bone mets and, different types of metastatic disease. And I've kind of twisted Dr. McIver's arm a little bit, and now I've got him going upstairs and making rounds with me on some of our inpatients. I said, you need to keep your hand in this pot. So that's one of the things I think that we do exceptionally well. And I think for the moment, I just want to, from a nursing perspective, because this is new to me and I'm realizing that there's not a lot of nurses that are here, I'm just going to throw it out there to all of you. In your perspective, what could a nurse do to help you with your visits?
Hi, I'm a nurse also.
Okay.
I'm retired. And I don't even know if there's a nurse in the clinic I go to. The medical assistant, brings me in, I talk to the doctor briefly, and then I go home. So I have really no one to talk to about
Mm-hmm.
So I think, your role is fantastic.
I think communication, because we live here, my daughter has papillary thyroid, but we're treated out of MD Anderson,
Mm-hmm.
and Dr. Wags has 2 nurses, so everything we do from our blood that's taken here goes there, and the communication, there's never a drop. You wouldn't know we're living out of state because they call us, when they get that blood work, they know we're parents, they know we're stressed out,
Mm-hmm.
and the communication is phenomenal. And then if you talk to the 2 nurses and Dr. Wags, they have the same message. They're involved so deeply with the same patients, and if I call one, I get the same message. And his top nurse that works side by side, you would never know she wasn't a doctor if you were just talking to her, and you probably know this. And then the hospital care, honestly, it's about hearing about that it's your kid. It's not just a number of a kid who gets medication at a certain time in a certain quantity. It's about who your kid is, calling her by her name, things like that make a huge difference for us.
You are, as patients, you are all, and caregivers, you are all incredibly inspiring to me. I look at all of you, and no matter what, it's in the back of your mind. Even if I'm free and clear and I don't have to come back for a year, as I get closer to that 1-year appointment, then you start with the, ooh, what if? What if this is the one appointment that things change? What about that? And to me, for all of you to look at you and you go on with your normal everyday routines and you excel, that's inspiring to me. It makes me stop and think, well, why am I worried about my hangnail that I've got? It's those little things. Anybody?
I would have to say, I'm on my 3rd endocrinologist now, and the hardest thing for me is that it's at a teaching university.
Mm-hmm.
Every year, and I only see my doctor once a year, every year I have a new fellow who sees you. And you have to go through that, getting to know them and
And
And it's hard, it's very hard when you want to get an answer out of them, and maybe they don't know enough yet.
I always say that behind every fellow should be an exceptionally strong nurse that knows when to stomp on them and say, you will listen to your patients. And I hear that too. We work in a teaching facility, and we do have a lot of fellows and residents and everything that come through both of the medical oncology practice and then Dr. McIver's clinic. And I do my darndest to pin every single one of them down before they go in to see our next patient and try and give them some kind of information on the patient. And Dr. McIver is exceptional because he will always go in too, and he doesn't always agree with them. But telling the patients, because I see that deer in the headlights look when I say, oh, Dr. McIver or Dr. Russell has, an oncology fellow or an endocrine fellow with them today, and they go, I'm not going to see Dr. McIver. Oh, yes, you are. And you need to, be honest with the fellow. And if they intimidate you or they don't give you what you need, you're driving this bus. This is all about you. It's not about how many patients that they can see in a day. It's what's important to you. And then when it's all over and done with, if you turn around and go, I'm not comfortable, with this, talk to me, and I will certainly make sure before you walk out of the room that you are very comfortable.
I just want to say that our biggest concern is a lot of times the labs. Before our son had his surgery, they did lab work, but the surgeon never got those results because the blood, they messed up on the blood and all that. So that was a big disappointment for us. And then recently he got sent for his 3-month lab work, and the lab didn't run the test that the doctor had ordered. So we had to go back. So a lot of times, I don't know if anybody has that problem where the lab doesn't run the test that the doctor orders. How that maybe they want to communicate better. I don't know.
Unfortunately, we do run into that, and I don't think that there's anything more frustrating because no matter what, it falls back onto us to say, look, I am so sorry. This is what's happened. I'm going to do everything I can to make it right. Sometimes it does turn around and you have to redraw the blood work, but I think one of the things that we both strive on is I'm not going to, snowball it. I'm going to look at you and say, you know what? I don't know what happened. There is a breakdown in communication, and for that I'm very sorry. But what I'm going to do right now, I'll be available afterwards. I'm going to introduce Dr. Bryan McIver from Moffitt Cancer Center.
Thank you. Sometimes they call me the late Dr. McIver. And today would be one of those days. So I drove straight from the airport, speeding all the way just to get here. But I really appreciate your patience, and I apologize for the delay. If any of you ever come to see me in the Moffitt Cancer Center, you'll probably experience the same frustration because I'm always running late. But Pam keeps me on course most of the time. So I think this morning's session is supposed to be about radioactive iodine use in thyroid cancer. Is that the correct topic of the? Okay, good. And the idea was to put out to you some new ideas that are coming along in this field. I'm not sure they're all that new, but certainly more people are adopting these ideas, new approaches and new evidence for the use of radioactive iodine. And of course, it goes without saying that radioactive iodine, if it's useful at all, can only be useful in those types of cancer that concentrate iodine. And those types of cancer come from the thyroid follicular cells, and those are the cells that make thyroid hormone. There are other cells in the thyroid gland called the C cells, which have nothing to do with making thyroid hormone. And those are the cells responsible for causing medullary thyroid cancer. So by definition, radioactive iodine has no role to play whatsoever in medullary thyroid cancer. It has no role to play in lymphoma of the thyroid gland. It has no role to play in other cancers that have spread into the thyroid. It specifically targets those cancers called papillary cancer, follicular cancer, and maybe poorly differentiated cancers that come from the follicular cell. Of course, that's the majority of thyroid cancers because something like 90-something percent, 95% of all thyroid cancers come from those particular cell types. I'm sorry, can people actually hear me at the back of the room okay? Yeah, okay, good. So, before we get started, I need to tell you, because this is a talk that's being used for continuing medical education, and one of the things we always like to do is tell people if we have conflicts of interest. Conflicts of interest means somebody else is paying me to do something that's relevant to this talk. And there are a few topics that I'll touch on that might have an influence on some of these conflicts that I have. I've done some scientific consulting work for companies whose names you may know, Veracyte, Asuragen, and CBL Path, and all three of those are in the business of marketing molecular testing for thyroid nodules in diagnosing thyroid cancer. And I've done work and been paid for that work. I also have research support from AstraZeneca looking at a chemotherapy for thyroid cancer, and of course that also represents a so-called conflict of interest. Is it really a conflict? Because if we don't do this research, then nobody's going to do it. Obviously, there's some benefit comes to our patients from doing this. None of that money goes into my bank account. But nonetheless, I announce it as a conflict so that you know where I'm coming from. But I will tell you that the only things you'll hear from my mouth are my opinions, and nobody buys my opinions. We also have to tell you, if we're going to talk about things off-label, what that means is things that the Food and Drug Administration has not approved yet, but which I'm going to tell you about as being possible treatments for thyroid cancer. And one of those is a drug called selumetinib, which has been used to improve the responsiveness of some cancers to radioactive iodine. It's an unproven therapy. It's an exciting new avenue that's being pursued, and it may turn out one day that we're using this drug to augment the response to radioactive iodine. It just hasn't been approved yet. So my purpose today, I'm going to try to make a case for an approach to manage thyroid cancer that is not just cookie cutter, everybody gets the same treatment, but rather which is selective and based on an understanding of the risk that an individual patient faces from that cancer. If it's a low risk, maybe that patient doesn't need quite such aggressive treatment. If it's a high risk, then for sure they need more aggressive management. I'm going to talk a little bit about a new idea coming along called adaptive prognostic methods. Adaptive prognostic methods mean that our understanding of the cancer changes the longer you have the disease. Maybe we learn whether your cancer is growing rapidly and needs more aggressive treatment. Maybe we realize your cancer responded better to treatment and we can ramp down on the intensity of our follow-up. That's called adaptive prognostication. And I want to specifically focus on some of the changing ideas about the role for radioactive iodine in the management of thyroid cancer. Now, I used to feel like this guy in this tank. I don't know, is there anyone can do something with these front lights maybe? Are we able to just dim those front lights to get a better view? But you can see this guy in a plexiglass box, surrounded by this huge crocodile. This is an Australian crocodile. And I used to feel a bit like this guy in that dish whenever I went to talk at national or international meetings about thyroid cancer and about maybe the idea some patients don't need to have radioactive iodine. I was called a therapeutic minimalist, meaning I'm not going to use treatments that I don't think are necessary. But I used to be a solo person in the room almost. Everybody else, all the other physicians would say, of course you should give these people radioactive iodine. We know that everyone gets treated with radioactive iodine. And so I was a solo person. I feel that things are changing. But back in the 1990s and early 2000s, this was the standard of care for thyroid cancer around the country. Many of you will have been exposed to this standard of care. Surgery to remove the entire thyroid gland, removal of lymph nodes from the central part of the neck behind the thyroid gland, removal of lymph nodes in the jugular chain, the lateral neck, if those lymph nodes were involved, of course. Radioactive iodine, either for remnant ablation, people would talk about ablating the thyroid gland, with 30 to 100 millicuries, and then radioactive iodine treatment, if there was any hint of cancer that was left behind, treating with 100, 200, 250 millicuries. There's one of our colleagues in Kentucky who has used doses as high as 700 millicuries of radioactive iodine. But this approach was very standard: suppress the TSH in everybody, and then monitor using TSH, thyroglobulin, stimulated thyroglobulin, whole body iodine scans, and increasingly ultrasound as well. And again, I think most people in this room are at least aware of that or have been exposed to this kind of paradigm. And of course, that made it very easy, because everyone got the same treatment, surgery, radioactive iodine, and all of these things. Everybody was happy. And of course, most patients with thyroid cancer do very well. The prognosis for papillary thyroid cancer in particular is excellent. 6% of patients with papillary cancer die of that disease. 94% live forever using this combined approach. So we're one big happy family. We can agree on everything. But what that was really missing was the idea that this is not just one disease, that people with thyroid cancer don't all fall into the same category. Why should we, and how could we possibly put this young woman in her early 20s who happened to have a tiny little spot of cancer, a 1.5 millimeter spot of papillary, what we call papillary microcancer, within her thyroid gland that was taken out for other reasons because it was enlarged and overactive? How can we possibly put her into the same category and anticipate exactly the same treatment as for this guy in his early 60s with a big goiter in his neck, and you can see on the CAT scan a big, nasty, invasive cancer spreading back and surrounding the blood vessels and getting back towards the vertebral body back here? You know, this guy has a bad problem. This is not a good cancer. This young woman has no problem at all. Even if that papillary cancer was going to cause a problem for her, it's now out, it's gone, it's done. This wasn't really a threat to her at any point. So why should we treat her and him the same way? And yet in 1995 through about 2010, that standard approach would have applied to both of these people. And so as a result, by being a bit more selective, we can avoid that kind of over-treatment for people who don't really need that aggressive treatment. Maybe we can be a little kinder to those individuals, avoid exposing them to the radiation and doing harm to them, because most of these folks will in fact live long and prosper, as Spock used to say. At the same time, it's important that we avoid the under-treatment that went along with this as well, because there were an awful lot of folks who bought into the idea that surgery and radioactive iodine cures thyroid cancer. And so some of these more aggressive cancers were actually under-ascertained, were under-treated. And those folks didn't have the advantage of having somebody really thinking deeply about their cancer in their specific circumstances. So avoiding the under-treatment and the under-investigation of those more aggressive cancers, while avoiding the over-investigation with the associated expense. You know how expensive this stuff is to get done. The associated morbidity, the side effects of our scanning and our treatments. And not only that, but the psychology of this as well, of taking somebody and putting them through whole body scans, withdrawing them from thyroid hormone, the whole chaos that does to your psychological state, I think we should be avoiding unless there's some real benefit to it. And of course, the high-risk patient probably needs that. So when it comes to kind of thinking about who should get more aggressive treatment, who should get less aggressive treatment, the thing for us to remember is that we need to understand the risk. And when it comes to the risk of cancer of any sort, we have to think about the cancer itself. We have to think about the person who's affected by that cancer, what we call the cancer host. And we have to think about those patient factors and the tumor factors in conjunction with the treatment effects. In other words, if you have a cancer where the surgeon wasn't able to take it out, you've got a big problem. Whereas if you had a cancer where the surgeon got rid of everything, maybe you don't have such a big problem. So treatment effects and effectiveness of our therapy is an important component when we think about the risk that the patient faces. Patient risk factors. We know in thyroid cancer, pretty much unlike any other cancer, that the age of the patient is a definite and absolute factor when it comes to the risk that the patient faces. Older patients developing follicular or papillary thyroid cancer are much higher risk than young patients. Somebody who's 18 years old and develops a thyroid cancer, even a very extensive thyroid cancer, generally that person's going to do well. Our treatments are going to work and the patient is going to live a long life expectancy. Somebody in their 70s who develops papillary thyroid cancer for the first time, the picture is not nearly so rosy. So age really matters. Men in general do less well than women. Sometimes that's because men don't notice the lump as early, they don't go to the doctor as often, they don't get checked properly, they put it down to just a sore throat, and so they get delayed in their diagnosis. But there may be some evidence that men actually have a biologically worse outcome as well. And that varies from one study to the other. And of course, increasingly nowadays, with the use of drugs for immunosuppression for a variety of things, somebody has a kidney transplant, somebody's on chemo for another kind of cancer, immunosuppression may have a role in releasing cancer and allowing it to grow, because your immune system is part of the process that contains cancer and prevents that cancer from spreading and developing. So immunosuppression, we think, is probably a risk factor from the patient perspective for that cancer doing badly. What about the tumor type itself? Well, we've known for a long time that there are different types of differentiated thyroid cancer that all come from the same basic cell type, from this follicular cell. We have the standard, most common one, papillary thyroid cancer, and that's what it looks like under the microscope, for what that's worth. We have the slightly more aggressive and much less common follicular thyroid cancer. It tends to invade a little more aggressively than the papillary cancer does. We have a slightly more aggressive variant of that follicular cancer that we call Hürthle cell cancer, which is actually also less likely to respond to our radioactive iodine treatment. And then we have the worst of the worst, the anaplastic thyroid cancer. And I'll be talking later today about anaplastic thyroid cancer in a separate setting. But suffice it to say here, that is a devastating disease almost always. And you can see how devastating it is when you look at the chance of dying of thyroid cancer. Here's the odds. If you are diagnosed with anaplastic thyroid cancer, there's a better than 90% chance you will be dead within the first 6 months. Okay, that's pretty hideous stuff. So anyone who tells you thyroid cancer is a good cancer, slap them upside the head and point them in that direction. Okay, anaplastic thyroid cancer is anything but a good cancer. On the other hand, papillary thyroid cancer, there's the chance of dying out over 25 years, so a quarter of a century of follow-up, and patients diagnosed with papillary cancer have a 6% chance of being dead of the disease in these data out of Mayo Clinic from many years ago. And then in between, follicular and Hürthle cell cancers have about a 1 in 3 chance of killing the person over a fairly prolonged time course. Most of those patients will live for years, but you can see progressive death out over that quarter of a century. So about 30% overall have died of their cancer in that time frame. So is that a real cancer? It is in my book. Is this a real cancer? Yeah, we need to be pretty aggressive for that beast. For papillary cancer, well, some patients don't do so well. The majority do very well indeed. We need to separate those who are going to do well from those who are going to do badly. And so that comes down then to the extent of the tumor. And what we know about the extent of the tumor is it really matters in papillary cancer and these other types of cancer. So we judge the extent of the tumor using a variety of different classifications. In this case, we're talking about the TNM classification. This is a standard terminology we use for all types of cancer. T is for the tumor itself, N for the lymph nodes that are involved, and M for the metastatic spread. That's the spread into other organs. And the TNM is a standard nomenclature, a way of describing the extent of a tumor. A TNM stage 1 is a cancer in a young person that's still contained in the neck. It can be in the thyroid, it can be in the soft tissues, it can be in the lymph nodes, but it's still in the neck. It hasn't spread anywhere else. That would be stage 1 for a young person. For an older person, older is over 45 in this particular scheme, so yeah, I've been there for a long time. So in people like me, if I was to develop thyroid cancer, it would still only be stage 1 if it was small and contained in the thyroid gland. Okay? If you are my age, 50-something, and you have a bigger cancer contained in the thyroid, it moves to stage 2. If that cancer is out into the lymph nodes or has started to invade in the soft tissues, it's stage 3, and you can see you're starting to face a real risk there of that cancer killing you. And then stage 4 is older patients with spread into the lungs or the bones, and you can see in these data from about 20 years ago that mortality, death from the cancer, was 100% within the space of 10 years. Okay, so again, papillary cancer, not a good cancer. Yes, ma'am, you have a question?
Different stage though for kids? Aren't kids now?
So I was just coming back to that because I started with the kids. Anything in the neck that hasn't spread is stage 1. For older folks, all 4 stages apply. But for younger people, it's stage 1 if it's still contained in the neck, and stage 2 if it has spread anywhere else. So if you're less than 45, you can only be stage 1 or stage 2. Yes, ma'am.
We actually got a diagnosis that says stage 4 for our 9-year-olds.
Well, they're wrong.
But so that's not even a.
No. So this only applies to differentiated thyroid cancer. That's papillary cancer, follicular cancer, Hürthle cell cancer. And in those cases, if you are less than 45, it is not possible to be called stage 4. Okay? And anyone who labels it as stage 4 doesn't understand the staging system. Okay? Now, actually, it's surprising because even at Mayo Clinic, we would occasionally see somebody where a data abstractor had pulled out something and say, this patient has stage 4 cancer because it's spread into lungs. They were failing to remember that thyroid cancer is unique in the staging system because it's got that age dependence. Okay? So here we are, stage 1, 2, 3, and 4. Stage 1 patients, well, most of them live forever. Okay? This was a study done at Mayo Clinic. I was involved in analyzing these data. 1,400 patients, 1,400 patients, followed out for more than a quarter of a century. And you can count the number of deaths that occurred on the fingers of one hand, literally. So out of those 1,400 patients, maybe 4 patients died. All right? A mortality rate of less than 0.4%. In other words, if you had stage 1 papillary thyroid cancer, pretty confidently you're going to live forever. All right? It's going to be a normal life expectancy. And the few patients who are going to do badly, we typically know about them up front because they have disease that doesn't respond to our treatment. And it just looks nastier. Stage 2, and that includes these young people with distant spread into other organs, still excellent life expectancy, 95% life expectancy with stage 2 papillary thyroid cancer. The stage 3, as you've seen, much more likely to kill you. It's still about a 75% chance you'll be alive at the end of a quarter century, but not everybody will be. And the stage 4, of course, pretty devastating stuff. Again, I would emphasize these data were up to 1997. So the last 15 to 20 years, we've seen a lot of changes in how we do things, new tools available to us. And what we hope to see is these curves changing out over time as we get better at treating it. Okay? They haven't changed yet that we can prove. All right, and it's very important to include treatment efficacy, as I've been hinting at, in our thought process about the risk the patient faces. If the surgical resection is complete and the margins of the surgical resection are negative, that's a heck of a lot better situation than where the surgeon's having to saw through solid tumor and leaves big chunks of that cancer behind in your neck. Very clearly, the outcome for those two types of situation are going to be very different. We like to look at the thyroglobulin measurement in the post-operative phase. Thyroglobulin, tumor marker for thyroid cancer. It's a thyroid tissue marker, but we use it as a tumor marker. And if your thyroglobulin after surgery is 0, there's a pretty high chance the surgeon has managed to remove all that cancer. On the other hand, if the thyroglobulin after a good surgery is 500, you best start looking for the distant metastatic sites because you know that patient has disease that has spread. And so post-op thyroglobulin is a very useful way to assess how effectively the surgeon got rid of the cancer. We like to use the initial post-operative ultrasound. In my practice, typically about 3 months after surgery, we do an ultrasound scan of the neck and try to see whether we got rid of all the cancer that was in there. Look at the lymph nodes. Look in the central part of the neck to make sure there's no little spots of cancer that have been left behind. And other imaging is sometimes necessary, CAT scans, MRI scans, depending on exactly the location we're looking at. But all of these things can help us to assess how effective was our treatment. And that, of course, changes the risk the patient is going to have a problem in the future. So we try to put all these things together, the patient factors, the tumor factors, the extent, the effectiveness of the treatment, and bunch it all together in some idea. This patient is low risk or intermediate risk or high risk, and there's a variety of different schemes to pull all those threads together. They started being developed in the 1980s, where they said age and gender and the type of cancer and whether it's invasive and whether it's spread matters, and we can prognosticate that way. And there's half a dozen of these different systems that share some common features. The one that I've used over the last 20 years or so is the one called the Mace scoring system. I used it because for those 20 years I worked at Mayo Clinic in Rochester, Minnesota, and it was developed there and discovered there by my colleague, Dr. Ian Hay. And so we relied on the Mace score. And here you can see the outcomes according to your Mace score. And you can go online and you can plug the numbers in yourself or have your physician do it and figure out, was your Mace score less than 6? Because if your Mace score is less than 6, you are going to live forever. Chances are you have stage 1 disease, or you're 46 years old with stage 1, 2, or 3 disease, but your Mace score is low, you're going to live forever. Out of those 1,900 patients, there was, I think, 2 people who died. Pretty good odds, you know. Almost you're more likely to be struck by lightning. You're much more likely to get into a car wreck than you are to die of your papillary thyroid cancer if your Mace score is low. But higher Mace scores do less well. So again, we get an idea very quickly of what somebody's future holds. This is my crystal ball number. When I see a patient straight after surgery, I have all the information, whether they have metastases, how old were you when you were diagnosed, how complete was the removal of the tumor, was the tumor invasive, and how big was the tumor. That's what those 5 things mean, MACIS. And if your Mace score is less than 6 on the post-operative day 1, I'm going to be looking at you and saying, I believe you're going to live forever. Okay, the chance that you're going to die of this disease is 0.2% or less. And therefore we can be pretty relaxed, not ignore it, but follow up in a more relaxed way. If I go in to see you and your Mace score is 7.5, I'm going to have a glum face because I say, hey, we've got a big battle ahead of us to make sure you're not one of the 50% who's going to die of this cancer. And that kind of idea that we look at different components of these risks and put them all together has been adopted by the American Thyroid Association in its new version of the guidelines that are going to guide physicians about how to manage patients with thyroid cancer. And the way that the ATA is doing this is to say we've got some patients that we know are at very low risk, we've got others who are higher risk, and others yet who are at very high risk. So we're going to call it high risk, intermediate risk, and low risk. And what we're going to do is to make a continuum of risk. And in the low-risk patients, we're talking about the papillary microcancers. The chance that that patient will ever have a recurrence of their cancer if you have a single focus of a small papillary cancer less than 1 centimeter, and it's been completely removed, the chance of ever having a future problem is less than 2%. The chance of dying is 0. The chance of it coming back, 1 to 2%. A multifocal cancer might be more like 5% risk of it coming back. Larger tumors with a little bit of extension into the surrounding soft tissues, we're now talking about 7-8% chance of it coming back. That's not the same as it killing you, but it's at least a problem we have to face. Bigger tumors still, those that involve lymph nodes, especially if they're bulky lymph nodes the physician can feel, then the risk is starting to rise. Here's about a 1 in 4 chance to a 1 in 5 chance that even after effective treatment, you're going to get a recurrence in the future. So we want to be a lot more attentive to those individuals and be willing to be a lot more aggressive about their treatment. And of course, the highest risk of them all, the follicular thyroid cancer, extensively invasive into blood vessels, where you've got a 30 to 50% chance that you're going to get a recurrence, and it's going to be about a 30 to 40% chance you're going to die of that cancer. So this risk stratification is something that I think all of us should think about on the professional side, and that all patients should be aware of as they face decision-making about their health. A question from the audience, sir. So age actually should not disappear from it, and this is one of the arguments that I'll be having with the ATA about the decision-making to incorporate this, because age is actually the most important variable, and it's why we won't only use this type of description to determine how we move forward. We will also use the Mace and the AJCC staging systems, and I like to actually have all of those data together. So when I'm seeing a patient, I like to know what was the stage, what's the Mace score, and where do they fall on the ATA risk classification. And I use all of that information to try and come up with a customized plan that helps that patient to understand what they face, number one, and secondly, help us to decide how to manage the disease. So let's give you an example. I'm sorry, there's a question as well. I think that's a very, very important question, and the answer is no. We don't know why age is so important. People have assumed it's got something to do with your ability of your immune system to kill the cancer, and that may be an element of it. As you get older, your immune system may be less capable. But the idea that at 45, you're going to have a worse outcome than when you're 35, does your immune system change that much? Maybe not. So it may be just the biology of the cancer. It may be, I'm sorry. Oh, good, perfect. So we got to talk at 11 on that topic. So there we go. Need I say more? All right. It's always good to have audience members who are more expert than I am. So, but the bottom line is, there's something about the biology of the cancer and potentially something about the host themselves that has an interplay that makes age very important. So here's a 35-year-old woman. She counts as young in the staging system because anything less than 45 is still young. She has a lump in her thyroid, you can see there, a 3.5 centimeter, it's about that size, cherry tomato size, 3.5 centimeter papillary cancer, and she goes through a total thyroidectomy, removal of the entire thyroid gland, and she has lymph nodes taken out from the central part of the neck, and it turns out to contain cancer in some of those lymph nodes, so it's a node-positive papillary cancer. Post-operatively, her thyroglobulin, 0.2. That's a very low number. Okay? And the question about where her prognosis sits is one that we should address. Now that we've done the surgery, do we need to do anything else? So here's her Mace scoring calculator, and you can get access to these in a variety of venues. The American Thyroid Association website has this calculator on it. I made an Excel spreadsheet that allows me to calculate it easily. All sorts of things. I think there's a version of a mobile app for your iPhone. You can plug the numbers in. But you can see the age there, size of the tumor, whether it was completely resected, were the lymph nodes involved, what was the grade of the tumor. That's something that the pathologist tells us. How ugly does this cancer look? Most papillary cancers are grade 1. And that gives us a staging system that's called a T2, because it's between 2 and 4 centimeters. T2, N1A, meaning the central compartment lymph nodes are involved. M0, that's the shorthand for saying no distant metastases. Okay, so it's a stage 1 cancer. Mace's score, 4.15, is less than 6, so she falls into the low-risk group. The AGES, which is another one of those scoring systems, is also a low risk, and the AIMS, a further one of those staging systems, all low risk. Everything is telling us this patient is at low risk. 35, 3.5 centimeter cancer, completely removed, lymph nodes involved, but very low risk. Okay, so there she is, AJCC stage 1, Mace's 4.15, low risk. And the question for the endocrinologist used to be, should she receive radioactive iodine? And before we answer that question, let me take that question from the audience.
So what if you were diagnosed as the other person and then you grow older?
Well, hopefully that's a good thing because you want to grow older. The only thing that leads you to restage a cancer is if something new happens. So let's say you were diagnosed like this woman at 35 and you're stage 1, and now she's 50 years old and develops a lymph node of that cancer. It's not very likely, but if it was to happen, she would leap from stage 1 to stage 4A because she's now older and can move into those higher stages. Okay? But if you're 35 and your cancer is treated in your stage 1 and now you're 75 and there's still no evidence of the cancer, you remain stage 1. That never changes. Sorry, say again?
If you had metastases as a young person and then you turn 45.
You stay stage 2, unless something new happens, and then we restage. Okay. So, should she or should she not receive radioactive iodine? For what it's worth, I can tell you that 5 years ago I asked that question of this case in an audience consisting of members of the American Association of Clinical Endocrinologists, and 98% of the audience's hands went up to say yes, this person must have radioactive iodine. I asked that question again at a similar venue just earlier this year, and about 98% of the hands went up and said, no, we probably don't need to do radioactive iodine. So there really has been a big paradigm shift in our approach to dealing with radioactive iodine. But here's the data, okay, this is the impact of radioactive iodine on recurrence rates in the, let me see, which one is it? Oh yeah, on the right side is recurrence, and on the left is death rates, okay? And these data were data developed by Dr. McIver, who was a huge name in this field for many, many years, and he had a large database of patients and analyzed what went on with these patients, and he was the one who showed radioactive iodine works and changed the entire approach to managing folks with radioactive iodine. What he showed was that if you use radioactive iodine in the orange, none of his patients died, whereas if he didn't do radioactive iodine in the green, about 12% of his patients died. And from that came the opinion that radioactive iodine was essential. On the other side, with radioactive iodine, there was still about a 6% chance of developing a recurrence of the cancer at some point over the next 3 decades. All right? But without the radioactive iodine, you can see here the chance of a recurrence was 40%. And so radioactive iodine really seemed to be working. And so as a result of these studies that began in the 1970s, the pendulum towards use of radioactive iodine swung to almost 100% use. Right? Why are we swinging back so far now? Well, there's a couple of things that I should point out. You can see here that the green lines were patients who received no therapy other than removal of the cancer. They didn't get any thyroid hormone. Okay? Anybody in the room who's had a thyroidectomy who doesn't get thyroid hormone, you're not going to feel very well for very long. All right? And what that group really consists of is people who had only half the thyroid removed in some cases, or simply the lump removed. Okay, some of these just had completely inadequate surgery. And so we're talking about comparing people who had inadequate surgery with those who had good surgery. And that may make much of the difference between these two groups. It's not just the radioactive iodine. So Dr. Mazzaferi's data, impressive as it was, simply set a question out there. Is it possible that radioactive iodine is the reason why patients are doing so much better in the later years of his practice? Okay. He included follicular and Hürthle cell cancers and mixed them in with the papillaries in that database. There were all sorts of different surgical types in there. The radioactive iodine was selectively administered to patients who'd had more complete surgeries, so you're biasing the data. There was no recognition of risk group analysis, so he was lumping the high risk and the low risk together. And there was essentially no evaluation of the use of radioactive iodine following adequate complete surgery. His data just didn't have that granularity, and so he couldn't do it. And yet for a long time we knew that the pre-existing risk made a difference to whether radioactive iodine worked or not. You can see here in blue were patients who were treated with radioactive iodine, and in red those who did not receive treatment with radioactive iodine. And you can see the benefit really just accrued in folks between about 40 and 60 in this very small study. There was no benefit at all in these younger patients. Down in the teens, 20s, 30s, and 40s, and no benefit from the radioactive iodine at all. And we looked at this in a lot more detail at the Mayo Clinic when I was there working with Ian Hay. And you can see here, these are patients who would be, I would count as low-risk patients. These were patients with a Mace of less than 6. And remember I said they're going to live forever, right? Well, here's the data for patients with any size of cancer involving lymph nodes, but disease that has not spread elsewhere. Okay? And you can see here that at Mayo, we did not treat about 224 of those patients with radioactive iodine. They got no radioactive iodine at all. And the other 303 did receive the radioactive iodine. So here's what happened with the standard Mazzaferi approach. If you give them surgery and radioactive iodine and treat them with thyroid hormone, you can see there was one death, but virtually everybody else, the remaining 302 patients, were still alive 20 years after their surgical treatment. Okay? Pretty good outcome. So Dr. McIver was right. Radioactive iodine treatment really works. So what about those poor souls, that 224 patient group, who did not receive the radioactive iodine? Oops, it's exactly the same. So does radioactive iodine save your life if you have a low-risk papillary thyroid cancer? No, because the outcomes are identical. Not surprising when you realize that all of those patients basically live forever. There were only 2 deaths out of 527 patients. Okay, so that's a tiny fraction of 1% mortality rate. You can't do any better than living forever. But what we think about is recurrence. What's the chance of a recurrence? If you have lymph nodes involved, that's what that N1 means, then you have a higher chance of recurrence. And there you can see, even with radioactive iodine, about a 20% chance that you would have a recurrence typically within a lymph node in the neck. Find it, treat it, and you still live forever. Nonetheless, that's another reason to think about radioactive iodine, to reduce the risk of recurrence. So what about the folks who didn't ever receive the radioactive iodine? Well, you can see again, identical recurrence rates. So radioactive iodine neither saves your life nor prevents the cancer from coming back. And that insight is incredibly important to convey to physicians who are looking after this cancer, because still to this day, there are many endocrinologists out there and other internists and physicians who think that anything the surgeon left behind, the radioactive iodine is going to mop up, and all you need is surgery and radioactive iodine and you're done. Okay, it is not so. With node-positive disease, there is a 20% chance of recurrence, even in the low-risk patients, even with radioactive iodine treatment, and the radioactive iodine really does not do very much. So people used to say, oh, that's just Mayo Clinic. Nowadays they say, oh, that's just Moffitt Cancer Center. They've got better surgeons, they say. They do different types of surgery, central neck dissections, and that's the reason for it all. Or when I wasn't listening, they used to say, yeah, they're just crazy. But actually, it's not just the folks at Moffitt and the folks at Mayo. It's actually data that is in the literature and solid and published from almost all of the major academic centers that have been involved in assessing thyroid cancer over the course of the last 20, 30 years. And these are data published in 2007, so they're not new data, from a multi-center study including all of the big proponents at that time of radioactive iodine use. And I will just summarize the data. I won't go into all the details necessarily, but just summarize the data by saying the conclusions were that our data suggest that post-operative radioactive iodine therapy, treatment with radioactive iodine, does not provide significant benefit in stage 1, that's the low-risk thyroid cancer, and could even be harmful. Because actually when they looked at the mortality, they looked at the death, it turned out that there was a statistically significant higher chance of dying if you receive radioactive iodine than if you do not receive the radioactive iodine. Okay? Now, is that just some statistical artifact? Is there something else underlying that? We don't know. But at the very least, they were unable to demonstrate in this very large study, multiple different centers involved, unable to demonstrate any benefit to radioactive iodine, either in terms of death or in terms of recurrence. And those data have been replicated as well, much more recently in 2012. Here's the data looking at recurrence rates in otherwise low-risk cancers, and whether you did or did not receive radioactive iodine, there was no difference between those groups. Both groups had an excellent long-term outcome, and radioactive iodine made no difference to it. So anyone who's telling you radioactive iodine is the magic wand and will cure you of anything that ails you really hasn't been reading the literature for the last 20 years. And we tried to pin it down. We tried to figure out, is there some subset of these otherwise low-risk patients who might benefit? So we looked at tumors that were unifocal, in other words, just one spot of cancer in there with no lymph nodes involved, and there was no difference in the outcomes. And we looked at those that were single spots of cancer in the thyroid but contained cancer in the lymph nodes, and there was no difference in the outcome. And we looked at those that had multiple spots of cancer in the thyroid gland, which gets some surgeons worried and endocrinologists worried. So this is the multifocal and node negative, and there was no difference in the outcome. And the node Positive and multifocal disease we looked at, and there was no difference in the outcome either. So at least amongst low-risk individuals with papillary thyroid cancer, radioactive iodine has no role to play, doesn't help us in either letting them live longer or reducing their risk of recurrence, at least according to the best data that's out there right now. But people say, it's hard to prove a negative. How can you prove something doesn't work? You know, you have to do a big study. You've got to do this prospectively. You need double-blind, placebo-controlled, randomized clinical trials and prove that radioactive iodine doesn't work. And nobody can ever do those studies because there isn't enough money to do the study that would involve 10,000 patients being followed for 20 years. It would cost millions and millions of dollars and actually wouldn't give us much information. And so people still tend to lean towards the use of radioactive iodine to this day, based on Ernie Mazzaferi's original data. And so I ask myself, okay, well, I'm not going to make a religion out of this, but if you're going to use radioactive iodine and there is no measurable benefit, can we at least be sure that there's no measurable risk? Are we doing harm with this radioactive iodine? Is it possible? Well, we do know salivary gland injury happens. People get dry mouth, dental problems, tear duct problems as well, with tearing of the eyes and dryness of the eyes. There's some evidence for bone marrow problems as well, and in high doses we know leukemia and lymphoma can be triggered by radioactive iodine. Changes in the menstrual cycle are pretty common after radioactive iodine, and menopause is brought ahead by about a year. You know, cumulatively that's a lot of osteoporosis. Male hypogonadism has been reported in a few cases, meaning men needing testosterone treatment and being sterile. But the big one is the second primary malignancies. And there's been good data on that in a variety of different places. I won't bore you with the details in the interest of time, but I can show you some evidence here from a European study published about 10 years ago by Dr. Rubino, who said that, you know, if you look carefully, you'll find that there is a 7.5 times higher risk of salivary gland cancer, cancer of the saliva glands, in people who've been exposed to radioactive iodine. There's a 4-fold increased risk of bone and soft tissue cancers, sarcomas. Uterine cancer and ovarian cancer is increased 2.3-fold after radioactive iodine. And colorectal cancer, it's not a big increase, 1.3, 30% increase in risk. But that's a numerically large number because so many of us do get colon cancer. So radioactive iodine actually triggers second cancers. Okay? And it does so in a dose-dependent fashion. And the kind of threshold, if there is such a thing, 100 to 150 millicuries, which are doses that many of us have been using for years in many, many thousands of patients. So we're probably causing a bunch of harm, causing a bunch of other cancers, and not actually protecting our patients from their thyroid cancer in doing so. So there is harm. Okay? It may not be numerically huge harm, but there is harm. Most of you in the room will know the name Roger Ebert, okay, who passed away not that long ago of a salivary gland cancer. I was never involved in his care. I've never had access to his medical record, and this is pure speculation. But it's interesting that he died of such a rare cancer when his original cancer was a thyroid cancer. And what I do know about that was that his thyroid cancer was treated with very large doses of radioactive iodine. And it's at least a speculation to suggest that radioactive iodine may have actually triggered his salivary gland cancer, of which he ultimately died. So I don't think that it's a good trade-off necessarily just to say we like to use radioactive iodine and we don't think it does harm, because it does. A question from the audience.
Just about Ebert, while that's certainly true, he was part of the same cohort that I belong to, little kids in Illinois who got lots of radiation
Yep.
for tonsils and
Yeah.
adenoids. And I think there's an elevated risk of thyroid, parathyroid, and salivary gland.
That is true, and certainly radiation exposure in childhood is something that is bad for all of us. I would just argue that radiation exposure, no matter what type, should be avoided unless there's evidence for benefit. Yeah. All right, so should this young woman with low-risk thyroid cancer really receive radioactive iodine? I've argued for the last 15 to 20 years that she should not. There was no evidence for benefit. Slowly the world is moving in that direction, and I'd like to think that most endocrinologists nowadays would avoid radioactive iodine in this young woman. Okay. I'm going to skip ahead in the interest of time because we are running out of it. So let me just tell you that when it comes to use of radioactive iodine, if you're going to use it, it's worth thinking about not using it in the low-risk patients. For use of radioactive iodine, we should consider low doses of that radioactive iodine because there's good evidence now that 30 millicuries is just as effective at killing the thyroid remnant as 100 millicuries. And you can do it using thyrogen or recombinant TSH, and you can do it just as effectively with low-dose iodine and thyrogen as you can the old-fashioned withdrawal and high-dose radioactive iodine. So if you're going to use it, at least use the lowest possible dose to avoid the unnecessary radiation exposure again. But for most of our low-risk patients, really no evidence for benefit, and they should be spared the necessity of the radiation exposure. I do want to point out one thing. Radioactive iodine is useful sometimes. And here's a case where I think it was useful. He was a young man, 21, very extensive node-positive thyroid cancer, papillary. Pathology revealed a 3.8 centimeter invasive cancer. And if we do his Mace score, if he doesn't have metastases, he's stage 1 and a Mace score of 5.24. But if he has cancer in his lungs, which is the most likely place for it to spread in a man of this age, then his Mace score becomes 8.24. And you may remember the curves over 8 carries a very significant chance that he'll be one of the few young people who actually does die of his cancer. And this is a situation where more aggressive treatment is justified. We measured his post-operative thyroglobulin after complete removal of the thyroid and all the lymph nodes, and his post-operative thyroglobulin was 5,100, which is very high indeed. So we know he has cancer left behind. Where is it? In his lungs. And you can see that black area in the lungs on the whole body iodine scan showing all of this intense uptake of radiation in the lung fields. And in fact, he had, 23% of the administered dose was in the left lung within 24 hours. That's a huge uptake of radioactive iodine. So the nice part about that, the bad part is he's got cancer in his lungs and stage 2 disease. The nice part is very avid for iodine. It's taking up a lot of iodine and it gives us the opportunity to treat him. And so we did treat him. Questions about how much to use, how often to use it, and when to stop are open questions out there. But what we did was to treat him with a total cumulative dose of 4 doses, 600 millicuries altogether, and then we stopped. And you can see what happened to his thyroglobulin. Just kept on falling. This was back in 2007 when this graph was drawn. And you can see his thyroglobulin had fallen to about 50 at that point. Most recently, about 6 months ago, thyroglobulin had fallen to less than 10, and it continues to fall, and there's no evidence of cancer. So radioactive iodine very helpful in these young people with well-differentiated thyroid cancer that has metastasized the lungs in particular. It can really be almost like a miracle cure. I hate to use the word cure, it's a 4-letter word and it's bad language, but nonetheless it's an excellent response to therapy. So his prognosis went from being devastatingly bad, Mace's at 8 point something, to being much better following the treatment with the radioactive iodine. Bottom line, understanding risk factors and risk group analysis makes a selective approach to differentiated thyroid cancer both possible and desirable, and can spare many patients the unnecessary expense of aggressive surgery and aggressive following up and monitoring and treatment without compromising oncologic principles. And at Moffitt Cancer Center, we've encapsulated that into our pathways of care. One of the signatures of Moffitt Cancer Center is we like to describe our care path using a formal pathway. And you can see here, although it's a little out of focus, you can see here we use staging, including the age of the patient, to answer whatever that criticism was about age, including the size of the tumor and the extent of the tumor and the Mace score, and we put it all into either a low-risk group, a intermediate risk group, or a high-risk group. Our low-risk patients, we measure the thyroglobulin about 6 weeks after surgery. Those who have a nice low thyroglobulin, we do not use radioactive iodine. If the thyroglobulin is greater than 1, we have the option to use radioactive iodine or to continue monitoring, depending on the discussion with the patient. If you have an intermediate risk, we recommend radioactive iodine with thyroid stimulation, and then high-risk patients, of course, are treated just like that young man I just described, with high doses of radioactive iodine. And so we stratify risk based on the stage of the cancer, the age of the patient, the type of cancer we're dealing with, and the response to therapy. And I think this is the way, really, of the future when it comes to managing patients with thyroid cancer. This is a similar kind of algorithm that will be included, I think, in the ATA guidelines in 2014. The bottom line is we've got to think much more carefully about personalizing the care of patients with thyroid cancer. Low-risk thyroid cancer doesn't need all of the aggressive interventions that we've typically used. We can use the staging to guide our adjuvant therapies, including radioactive iodine, and guide our follow-up. And the goal should be for long-term, minimally harmful follow-up for patients with low risk. And I keep saying low risk. I should emphasize that's about 85% of all the patients with thyroid cancer. So this is the majority of the times. Most patients will live long and prosper, but the high-risk patients need to be identified, managed and treated more aggressively, and followed using all of the tools that we can bring to bear with modern medicine. The role of the endocrinologist and every care provider needs to be to treat those patients who can benefit from the treatment and spare those patients who don't need the treatment from the harm that we would otherwise induce. I appreciate your attention today. I really appreciate your patience with my late arrival, and I'd be happy to take questions if there are any offline. Yes, sir.
Takes us